Hello, and thank you for coming. Happy Friday. Welcome to our Assisted Outpatient Treatment Community of Practice. If you received our email reminder, you know that today we're going to be talking about success in AOT and what that looks like. So we've convened a really amazing panel of interdisciplinary professionals to talk about what success looks like from their role in AOT. So I'm really, really excited to talk about not only what defining success in AOT, but also I hope that at the end or maybe throughout, we'll have created a space that allows us all to acknowledge, the progress that we make in this work and our wins, no matter what they look like. Because as we all know, this population that we're working with is highly acute, and what can be seen as a good outcome or success, with AOT clients can look a lot different from other consumers of mental health services. So yeah, so thank you so much for coming. We'll kick off this session today by having the panelists give a brief introduction of themselves, and then we'll go ahead and dive right into questions. If you'd like to, save your questions for the end, that would be great. We're going to allot some time at the end, as we always do. And but if if you need to get something out right away and don't want to forget it, then go ahead and drop it in the chat. Um, but just a quick note before we get started that the opinions and views shared here today by the panelists that we've chosen is those of the individual professionals, and they don't necessarily reflect those of the Center for Behavioral Health or Justice or Wayne State University. So, and always, like I do every month, there's a lot of new people here today, so this is a new plug for you. But I always want to make sure to mention our AOT Q&A sessions, where twice a month we have Dr. Scott Smith, who's actually on this call and on our panel today. He's available twice a month to answer AOT related questions, whether that be like a case consultation kind of thing, or questions about the processes of things. So it is a drop-in, so you can come anytime within that hour span. So this is also, we found a great resource for, for families and advocates of AOT, whether it be AOT consumers or their families or loved ones, because there's a lot of questions and AOT is a very mystified space. So this is also a good resource to share with them if they'd like to talk to a professional about, what them or their loved ones are going through. So as AOT, gets more attention across the state, more questions are going to rise, and we want to make sure to share this information internally and also externally across the state so that, if folks have AOT questions, they know they have a place to go. And always, if you do have questions in the meantime, you can always reach out to me. We're always available to answer questions and to be able to give guidance however we can, either via email or, referencing our AOT toolkit. So for the Q&A sessions for February, it looks like they're on Monday, February 9th from 11 to 12 p.m. and Wednesday, February 18th from 2 to 3 p.m. So again, go ahead and check those out if you have anything that you'd like to, talk about when it comes to AOT, if there's any questions that you may have. And if there's any questions here today that don't get answered, then feel free to join those sessions. And finally, our final announcement is, I'm not sure if you all are aware, but we have a crisis response initiative at the CBHJ as well. And they also put on a community of practice on the first Friday of the month, as opposed to the last Friday like we do. But there's, for February, I'm letting you guys know that for February, we're doing kind of like an AOT crisis response collab. So we have our amazing partners from Washtenaw agreed to come to that COP and talk about how they've embedded a lot of their crisis response procedures and AOT procedures, how they've, really integrated those two. So it should be extremely, extremely fruitful conversation. And, if that's something that you're curious about, the intersection of crisis response and AOT, then be sure to check that out. I'll go ahead and include that in the follow-up email, and I'll also put it in the chat today. So, I'm gonna take a breath, so many announcements. But before we start our main discussion today, I'm gonna have our guests introduce themselves. So, panelists, I'm going to ask you to go ahead and share your name, where you work, and how you work with AOT in your position. So I'll go ahead and call on you because everybody's ordered differently in my on my screen. So we'll have Hailey go first.
Hi, my name's Hailey. I work at StoneCrest Center. I'm a court liaison, but also do a lot of care coordination with outpatient providers. And I'm a MSW student at Oakland.
Wonderful. Thank you so much. And Megan, you can go ahead and go next.
Hi, I'm Megan Hebert. I work for Oakland Community Health Network. I am the project lead of our assisted outpatient treatment team. And really, my role is to kind of support the team with some of their questions. I'm the primary contact for our provider network and court as well. So, really, just kind of supporting the team, answering questions, supporting the community as a whole.
Wonderful. Thank you. Mac, go ahead and go next.
Good morning. I'm Mac Hohmann. I also work for Oakland Community Health Network. Prior to that, I worked for Common Ground for about 17 years, and I was entitled the AOT monitor at Common Ground, but because I was really a one-man show, I really didn't have time to do much monitoring. Now I'm at Oakland Community Health Network and we have a team, so we can get a lot more done. Here I am the probate court liaison, so I spend most of my time writing alternative treatment reports, and typically that includes a recommendation for AOT and the services that should include. But, I'm also a community contact for people who have questions about AOT.
Wonderful. Thank you so much. And we'll go ahead and turn it over to Scott.
Hi, Scott Smith. I'm a technical consultant with the Center for Behavioral Health and Justice and Associate Professor of Social Work over at Oakland University.
Wonderful. All right, those are all of our panelists. We did have an individual from a probate court that was supposed to be here, but unfortunately could not make it. So yeah. But we will go ahead and start with the first question. And I just want to note that for panelists, I'll be calling on you to answer questions. But if there's something that another panelist says that you're like, oh, I want to piggyback off of that, then feel free to interrupt me and go ahead and jump in. But yeah, for the most part, I'll be calling on you. And for the audience, like I said, we've allotted time at the end to answer questions at the end. So don't hesitate to drop your questions in the chat and we'll address them after the panel. So, all right, let's go ahead and get started with our first question. It's kind of a softball. So, when you think about a successful AOT case, what does that look like from where you sit? And we can go ahead and start with Mac for that one.
Well, thank you. One of the things that I would consider a success is even if a person does not gain insight, as we like to call it, if they can express some understanding of how treatment has been helpful to them, I would call that a success.
Wonderful. Wonderful. Megan, do you have anything to add to that?
I think it really depends on each case. I think that you can't really put like a specific criteria on what a successful AOT case looks like. For example, we had one individual who, we have been dealing with for quite a while, who's been on an order for a while, and we finally were able to get him agreeable to join ACT. And that was huge. For me, that was a win. Even though he's on an order, he needs that level of care. We're hoping that now that he's in ACT, we can start the process of hopefully getting him more stable long term to be able to have him not be on an order again. So, I think it's really meeting where the person's at, and seeing, like what Max said, it's the small successes. We had another individual who one of our case managers worked with, Al, and I would say that he, was a huge success in that he was on an AOT order and really working with Al and his treatment provider. He was able to improve his family relationships, able to get employment. He improved so much to the point that an AOT order was no longer needed. So,
Good job,
in,
Al. He's
So
right there.
I figured. So I think for each individual, it just depends on so many factors. For the one that Al worked with, he had a family, he had a support system. For other individuals, they may not have that. They may not even have a stable place to stay. So I like to look at it as, just looking at the small wins for me is, I think, a success.
That's wonderful. Yeah, thank you so much, Megan. I think you highlighted some really good points there that it is case by case. And, success can look something like, rebuilding family relationships or, just simply agreeing to or enrolling in services that they extremely need. So thank you for going into specifics and highlighting that. Hailey, why don't you go ahead and go next?
Sure. On the hospital end, success doesn't necessarily look like, or doesn't always look like no hospitalizations or someone never coming back in the hospital. Sometimes it can be just that longer gap in between hospitalizations. Sometimes people still need that kind of like med changes or they go through something in their life. So not necessarily never being hospitalized, or just those shorter stays when they do come to the hospital. I'm always really encouraged too when we do have people come in and they can tell us who their outpatient provider is. That seems like a small thing, but from people who come in and they've never been to outpatient, or they do and they couldn't tell you where they're going, as opposed to when they come in, they're like, yep, I go to team, I go to CMH, I get my shot every so many weeks. Those little things kind of show us that like, okay, well, something in there is working. They might not have the most insight, like Max said, but it definitely shows us some kind of progress.
That's great. Thank you so much, Hailey. That's something I've heard echoed across the state as well, is that, when looking at hospitalizations, when just seeing a decrease in the length of stay or if a client goes from, going once a month to maybe going a couple times a year, that's a win. So thank you for highlighting that. And Scott, why don't you go ahead next?
Sure. I think from an emergency department stat perspective, there's two things. One, it looks like a reduced frequency of visits, similar to what Hailey mentioned. Maybe it's not that the higher utilizers completely, stop coming, but the frequency is reduced. On the other side of that is improved coordination between entities. AOT, one of the big assets is that it can allow us to do better coordination of care and to get past some of the normal challenges that we have in coordinating care between separate entities, right? So while HIPAA does allow us a lot more latitude, I think, than we often take advantage of, certainly in cases with AOT, especially when the order allows for, the cross entity communication, it really does facilitate better overall care. There's lower incidence of the times that individuals are in the ER and nobody from their treatment team is even aware of that. So that would be, I think, one of the greatest assets that in terms of how success looks in the ER.
Wonderful. Well, thank you so much. And so the next question is, what is something that your system or organization considers a win that another system might not consider? And why don't, Scott, you go ahead with that one?
That's a good one. So obviously, a reduction in visits might be considered a win for the ED, just in terms of resources. On the other hand, if that individual is ending up taking up, time or space somewhere else, it might not be a net gain overall, right? It might just be shifting the resource expenditure from one location to another. And it's a good reminder that, especially when we consider how much contact individuals on AOTs typically have with siloed entities like the criminal justice system, the emergency departments, CMHs, et cetera, that we're probably each individually unaware of just how much effort, how much utilization is happening in the other arenas.
Wonderful. Thank you. So let's give it to Megan.
So I think for us, one thing that I really think is a win where another entity might not is our providers emailing us, asking questions, also updating us saying, hey, this person we haven't been able to connect with, that person may still end up back in the hospital, may end up on an order again, but just the fact that we have more of our contracted providers updating us on, hey, this person, didn't show for their intake. What should we do? How can you help? Or, hey, this person is not taking their meds. What's your suggestion? It shows that more of our provider staff are aware of AOT, paying attention to the people on their caseload and recognize that, oh, okay, these people might need a little bit more help. That's one of the things that we try to push is like, if you have someone on your caseload who's on an order, they might be someone you probably need to watch a little bit more, provide that little bit more support, reach out to us for help or, your supervisor. So for me, that's been a huge success since our team has really been put into place is just the amount of emails that we're getting is increasing a lot. I feel like just having that connection and knowing that we're getting out there, people are knowing who we are and that we can help is a big win for me.
That's great. That's amazing insight. Do you have anything to add to that, Matt?
Well, I would go in just a little bit different direction than Megan. She tends to be more systems oriented, and I'm maybe more individual oriented. I would say anytime that we can keep a person in treatment for the length of the order, that's a small win because every day we have with them, every contact we have with them, that's our opportunity to plant a seed that you may not realize it yet, but this is helpful for you.
Great.
And we may never reach a point where a person even says, well, yeah, I think it is because of the treatment I'm getting that my life is better. But I do have to consider the possibility that, yeah, maybe my life is better when I'm in treatment.
Mm-hmm. Definitely. All right. Hailey, from the inpatient perspective, what do you think?
On there's just so many different factors that kind of overlap with inpatient. Seeing someone is following up with their outpatient services, especially if there's someone who's been in the hospital before, seeing that they've been, going to their provider and continuing with those services, even though the hospital wasn't the one providing those services, that can, it makes a big difference on our end. And seeing too, when somebody comes in and they automatically have placement, either they're able to go back to a family member or they're able to return to their AFC home, is kind of always a immediate positive just because it shows us that they have those relationships and they're able to maintain those relationships and have those kind of support. So, it's a positive, but also kind of shows us that they might be able to have that continued support when they discharge too.
Yeah, definitely. Thank you. So the next question is, can you describe a moment where cross-system communication made the difference between escalation and stabilization? So Mac, can you take that one away?
Yeah, that's going to be a hard one for me because, as I was just saying, I'm more of a, focused on the individual. So if I may, I'm going to slough that off on Megan.
Yeah.
Sure. So I think one specific example that comes to mind is we had somebody who was homeless with our provider at a higher level care, I believe on the ACT team. This individual was not engaging in treatment and would frequently show up at like a local walk-in clinic. It usually wasn't an issue, but this person started to kind of decompensate in front of their eyes. They were noticing that he was making some inappropriate statements, seemed to even start, verbally getting a little bit aggressive, trying to use substances while he's inside of the clinic. And so the clinic was able to find out that he was on an AOT order, and reached out to us. From there, we were able to connect with a treatment provider and then kind of figure out a game plan because this person we don't have a resident, so we had no idea of how where he lived to have law enforcement come pick him up. So what we had to do was really work with the clinic on, them calling me, hey, he's here. Okay, let me, call law enforcement. Let's see what they can do. It was a lot of us working together, and being patient, to kind of help support the individual. And working with law enforcement, we were able to get the person back into the hospital, before, he, decompensated further, before there was an incident of him getting aggressive, before law enforcement had to, actually get involved, because they made it very clear that they have had frequent run-ins with him, on many occasions. So I felt like it was a good team effort of everybody working together, to make sure we got this person back in the hospital, because that's what he needed to get stable.
Mm-hmm. Wonderful. How about Scott? We'll go to Scott next.
Yeah, and this actually goes back a few years now, but an individual who had a co-occurring SUD on top of his serious mental illness, frequently would see him in the ER, not with a psych-related issue, directly psych, but with incredible levels of intoxication. We're talking in the mid 300s routinely. And this individual had experienced so many setbacks because of the nature of the co-occurring disorder, and even had a loss of a limb due to issues related to his chronic alcohol abuse. So this was an individual who finally was able to get on an AOT and ended up being placed in a spec res setting. A year and a half goes by, don't see the person. Staff actually comments like, wow, we haven't seen so and so. And our assumption was that he had likely passed. And then we actually saw him with a wound infection a year and a half later, but it was a routine, wound care issue. He was sober. He was an entirely different person. And it was just clear that, once that treatment had really been engaged, that he was able to have a huge turnaround. And it was encouraging, especially because it featured that co-occurring issue, which I know is an area that there's a lot of, discussion. How should we try, et cetera, with AOT when there is that substance use piece. But this was a great example of people actually figuring it out, making it work for him. And he was living an entirely different life. And it was really encouraging.
Wonderful. Hailey?
One of the cases we've had that stands out to me was an older gentleman, kind of with those, fixed delusions, who's going to probably have some kind of lifelong psychosis, but was, otherwise stable. But finding placement was especially difficult because of his delusions. But we were able to find a group home who was not only willing to accept him, but was able to get on a couple Zoom meetings with him so he could kind of see that they're real people. They could talk to him about what his room would look like, what kind of things he's interested in. And he just said, he just wants to be able to watch TV and go to the grocery store, and for him being able to make that connection with them and them reassure him that, like, yeah, no, we can do that. We'll get you to your appointments. We can go to Kroger. There's one down the street. The social work staff, we kind of pulled up on maps where his house would be and that kind of thing. And after that one, it was a process. It took probably, a couple of weeks to find that placement. And then along with his outpatient provider being able to, schedule those appointments and coordinate with the group home. I think it's been about a year and a half and he hasn't presented back to the hospital. So that's probably one of my, top scoring cases.
Yeah. Well, thank you all. I love that your answers highlight that success in AOT can be seen as cross-system collaboration. So every time you're working on building a relationship or are connecting with providers, like Megan said, you're breaking down those silos that serve as a huge barrier in this work. So that in itself is a huge success. So, so yeah, congrats. The next question is, with AOT having gotten a little bit more traction over the last couple of years and more eyes are on AOT, what process improvements have you seen in your organization or maybe statewide that have made AOT more humane or efficient or effective? Hailey, why don't you start with that one?
Over the past couple of years since I've been in this role and engaging with the different AOT programs, I've seen more judges getting more involved in the AOT process, kind of looking at it as more of an opportunity to connect with their consumers and, you know, really trying to learn about the different aspects, learn about what the goals of the AOT are. Um, and I think that's been a big shift, you know, especially in some smaller counties where the same judges are doing the mental health proceedings and the guardianship proceedings. I see that they actually kind of get to know the individual, and then the individual as well. It kind of, you know, when they do end up having to come back to the judge, even if it's just for like a review hearing or a touch base, it almost kind of seems like it's a motivating factor for the person, you know, that like I have this person in this position who's kind of rooting for me and not so much, you know, trying to get me in trouble or anything. So that's been kind of a big change. And then also just some of the judges in court systems who are willing to take the time to meet with the CMH and the different agencies in their area and to kind of get a better idea of how mental health treatment works in their area and with their systems. I think that's helped a lot on both ends.
Wonderful. Scott?
Well, Hailey took what I was going to point to, but my next example actually would be the improvement I've seen in the CMH coordination. Really, that's made a huge difference. And since we're all friends now, the biggest difference I've actually seen are in the clients that, well, are really, really, really hard to like. The clients that we struggle with that are just so difficult. Having the AOT does something, it appears, to clinicians, whether it's give them a greater sense of empowerment that, like, listen, maybe the rapport is not being built the way we normally would like to, but I still have a job to do, and you have a court order to do it with me, so we're going to make this work. Whatever the mechanism has been, I've seen just a much better like engagement with especially these really challenging clients.
Wonderful. Megan?
So I think for me, the one of the big things is just the fact that OCHN was able to really push for funding and make our team. That's huge. You know, I know other counties, there's some counties that have one person, maybe one person. So I think we're really lucky in that OCHN has made this a priority and has seen the benefit long term. So for me, I think that's really important. And I know I would say the other thing is just kind of the push for cross collaboration between counties. So we have recently have had some situations where I've had to interact with Macomb and I've had to interact with Wayne, and just how smoothly it's gone, how I think not like, well, they're their person and you're no, they're you know, do you know how sometimes there can be a lot of like back and forth of like county who's responsible of the individual. I felt like it was a lot of just, hey, you know, this is what's going on. This person has moved to your county. Here's all the information. I just felt like the sharing of information has been smoother, working together collaboratively, supporting each other, which I think is huge, because we have those individuals who hop between all the different counties. And so the fact that we're able to see us work together more collaboratively is going to be important because we will better be able to support those individuals and know what's going on, you know, if they hop to the other county or they come back. And, you know, I think we just will hopefully have better options to support that person in hopes of getting them in a more stable state.
Great.
Or kind
Yeah.
of the inverse of that is a person might somehow go from Oakland County and be hospitalized in a county several counties away, and we may never hear about it.
Mm-hmm.
If they have a court hearing, typically they would contact me and I would take care of the ATR. But I think I'm still on the same question, but I am very encouraged by groups like this and by the improvements that we've made at OCHN, to have a team approach to AOT and not just have one person doing that. Happy to see that we have made some inroads with our judges. Particularly, we have asked them to, in their orders, include a direction that the person contact us for an access screening or a justice liaison review, just so we can make sure that they're in the best treatment available. We are hoping someday that we can do reviews with judges on AOT cases. So far, that's not happening. But we have had some meetings with our judges and hope to have some more. And let me see if there was anything else I wanted to say on that. No, I'll leave it there.
Great. Well, thank you. Thank you so much. So the second to last question that I want to ask is, what is one thing that each system can do to make success more likely for the other systems? So Scott, why don't you go ahead and take that?
I think the biggest area of opportunity right now is improved communication between different systems. One of the challenges that, in the ERs we've always seen is there are individuals very well known to us that are unknown to other parts of the system. And I think specifically about those individuals with serious mental illness who have Medicare primary. And they only come on the radar of the CMH when they use up all their Medicare days. And so now the secondary Medicaid has to kick in. And unfortunately, the Medicare itself does not lend itself to the type of care that they need. They need other services that are only going to be available at CMHs and not at like an outpatient psychiatrist's office alone. And this, by the way, even extends to long-acting injectables. I see so many private psychiatrists who just don't either want or have the capacity to stock long-acting injectables, and so they're not using them despite the fact that they know this client isn't going to take their oral meds. So those clients in particular, I feel like really are the most in need of AOT type services, and yet there's not a natural mechanism to increase this coordination. And something I've said in other COPs we've done where I talked about the role the ER can play is, I think the ER, just like every other entity, has to consider taking more initiative in getting, an AOT evaluation started. We ask law enforcement to do that. We should be encouraging ERs to do this. And I know this is met with some very strong opposition. And here's my argument. If nobody knows this person exists and is in need of care, nothing's going to change. So, this is really an area where I think a little front end extra effort could pay off significantly on the back end, both for the organization and especially for the individual.
Wonderful. Thank you. Hailey?
I think kind of like what Dr. Smith said, communication between the different systems is can make a big difference, especially between hospitals and the CMH and the outpatient providers. I know when individuals who are especially ill, present in the hospital, it can be difficult to get much information from the individual. So it's think it's especially important to be able to communicate with the CMH, especially if it's someone who they're familiar with. And I think too, one of the ways that we can kind of help facilitate or improve that communication between the hospitals and the CMH is taking advantage of the utilization management or utilization review teams at the CMH. Especially when, Medicaid is the funding agency, the CMH's UR staff is speaking with someone at the hospital every couple of days. So I think that's one way to kind of connect the different groups, especially whoever is, responsible for court orders or AOTs and the treatment with the hospital. Even if, the hospital doesn't know who, is responsible for AOTs at the CMH, or the person can communicate with the CMH. Hey, we have this individual who's at the hospital. They're going to get put on a court order. Maybe can we connect with them before they leave? That kind of thing.
Great. Matt?
I'm going to ask you to repeat the question for me real quick.
Yeah. So what is one thing that each system can do to make success more likely for the other
Thank you.
parts of the
Okay.
system?
All right. You almost can't overstate the importance of communication. And then I would hope that that communication would lead to a shared vision of what we hope AOT looks like within that system. What can I expect from your party? What can you expect from me? If we have very different expectations, we're never going to be happy. We're never going to feel like we have success.
Very well put. Thank you so much. Megan?
So I think just piggyback on what Max said, like we have a perfect example. We have an individual who we've had some issues with law enforcement being willing to take the person in. So they have several reasons as to why, what they're willing to do and how. And so, we have a meeting scheduled. We have a co-responder who's located in at that particular city. So we're actually having a meeting with the co-responder, myself, several people from the provider to kind of collaborate and talk about like, hey, this is why law enforcement can't do this. This is their reservations. Let's work together. How can we, support when we need to get this person picked up? How do we accomplish that? Because the provider was calling the court and the court's like, well, they have to do this. Well, they say that, but we all know, like they say that, but doesn't mean it's necessarily going to happen. So I think that shows to just how what Mac had said and kind of what everyone said, that just that collaborating, because instead of working against each other, the provider working against law enforcement, we will come together. Let's express our concerns, our barriers, and then come up with a plan. So when this happens in the future, we all are on the same page and we can all reach the same goal, and hopefully minimize that frustration. So for me, again, I think everyone has touched on it, but communication and collaboration, because at the end, we all have the same goal. So it's how can we accomplish it by supporting each other and, recognizing that there are some limitations because we can only do so much and there's other parties involved. So it's just, let's try to work together, make our lives a little bit easier to get to that end goal.
Wonderful. Thank you so much. Thank you so much to everyone. These answers are extremely insightful, and I really appreciate this opportunity to elevate everybody here on this panel and the amazing work that they're doing. So the last question, I'm not going to call on anybody. I'll just let whoever wants to take a stab at this question go right ahead. But we've shared a lot of wins today and what success looks like in AOT. So I'm wondering, how do you share those wins with other parts of the system or your community partners? And if nothing comes to mind, then how can you share wins with other parts of the system or community partners? So anybody who wants to start, go ahead.
I can go first. We're lucky that we have a management meeting that meets every month, and we have a steering committee that meets every quarter. So that's a big way that we can share some updates. So that's how we share the wins, share the concerns, also ask for feedback from all the stakeholders. So that's been really important. and helpful. Sometimes also it does just look like sending a quick email, to a stakeholder that we're working with, and I know Mac had mentioned we have had a few meetings with our judges. They've been short, but during that short time, we really try to like make a point to point out exactly, the win or the concern, to right to the point. But I think that's, another way that we've been able to share the win is just by having that, that quick meeting.
And to qualify short, yes, they were shorter than we would have liked, but they did let us go over time.
That is true. The last meeting they did, I was very impressed. The last meeting, yes.
That's wonderful. Does anybody else have any other thoughts on that one? How we can share wins with our partners?
For me, I think being able to just identify even the little wins, it's what keeps me going, at least, in this field, especially in the inpatient side. We see a lot of negative. We see a lot of people in, the hardest times of their lives, so being able to identify those little positives, those little wins. And I try to share them with our, different community partners when they come up, especially if it was a case that we were working on together. I'll every couple weeks I'll call Meg and I'll be like, do you remember so and so? I just found out that this happened, or yeah, they've been here for 6 months, but their mom's letting them come back now. Things like that seem like really small, but for me they're exciting. So I try to share that with everybody else too.
That's great. Scott, did you have anything you wanted to add?
I was going to say that I think, encouraging clients who have been successful to share their story, to reach out to those entities that they've had contact with. I was talking to a friend of mine who works in law enforcement, and he actually got a card from somebody he frequently had to transport to the ER. And it was a thank you, and basically telling him like, I'm taking my meds. I've got a job now. He actually mentioned he's got 2 girlfriends, and he never would have been able to juggle relationships if he didn't take his meds. So I guess whatever the motivation is, like fine, it works for him. But encouraging that, and it might even be beneficial down the road to start looking at how we can use organizations like NAMI to really kind of highlight this, because so many natural supports really, they survive going from encouraging moment to encouraging moment, and the more of that we can provide, the better. So I think that that's another way to kind of get that message out there.
Wonderful. Wonderful. Thank you so much. Thank you to all panelists. This was amazing. I hope that I hope that you all can feel like you have, like you do amazing work, and this is a space to celebrate that. And it's amazing to hear how you share that with other parts of the system. That's really amazing. So we'll go ahead and transition into our Q&A part of the event here. And I want to also say, we are going to address the questions in the chat, and I will take questions. But I also want to encourage, if there's something, if there's something that this discussion brought up for you, in that you're like, oh, that was handled really well, or yeah, I would consider that a win, then I encourage you to share that as well. This is the space for that, for us to, be here together and to lift each other up and celebrate our wins together. So we'll go ahead and start though with a question from Barbara in the chat, which is very insightful. How can you help get the court side, quote, or judges and lawyers, to get willing to see other sides than just a doctor's voice, and to have an understanding of the clinical limitations that do exist? So yeah, I guess Scott, I see Mac's hand up. We'll do Mac and then Scott.
Okay. Well, sorry to interrupt your flow there. It's a challenge. I think the hospital tends to be seen in court as kind of the top of the pecking order, as the experts, and sometimes we get short shrift on that. But as the probate court liaison, I'm not only writing the alternative treatment report, making a recommendation to the court, and I've been doing it long enough that I think I have some of the judge's attention by now, and they're willing to at least consider my opinion. Also, I'm attending the probate hearings, and I will sometimes ask if I can make a comment or two when I think maybe the hospital's recommendation is missing something. And the judges don't always let me talk, but sometimes they do, or sometimes they'll say, well, Mr. Hohmann seems to have something to say. Do either of the attorneys want to call on him? So I have been able to get a change made that way.
Wonderful. Scott, did you have anything?
Yeah, I was just gonna say, I'm encouraged that Christina Morgan, who's now at the Scale office, is the one person behavioral health director. I'm encouraged by a lot of the work that she's helping to spearhead to get better training to judges and attorneys around the state. And I think one of the challenges is that very often sometimes it's the side of the prosecutor, sometimes it's the side of the defense attorney, but they don't know enough about mental health to know when to speak up or to object, or even the best questions that could be asked. And so that can often result in a inability for a defense attorney, let's say, to properly defend their client and push back on that testifying, doctor. And on the flip side, it can stop a prosecutor from stepping in and, if they do have a maybe overzealous defense attorney, stepping in and asking different questions to make sure that, the CMH's and or the hospital's voice is heard in that occasion. And ultimately, if we get more judges, educated on mental health, educated on policy, procedure, et cetera, that's going to make an enormous improvement as well, because I've seen judges be able to ask really good questions, and that forces people to have to like pause and consider, for example, Malcolm's ATR, and really have to look at that and consider what else could be going on.
So a different question that I had that I wanted to wait to share, in case we didn't have any other questions, is if the public or policymakers were listening, what would you want them to understand about what AOT successes really look like? And again, I'll just throw it out there, and whoever on the panel wants to take it, then run with it. Mac.
Okay, well, I would like to quote a couple of people that I think most of us know. First of all, Eric Smith, who I've seen at some of the AOT consortium. He's from Texas, a consumer himself, and he said that AOT made me fall in love with recovery. And that's the way I would like AOT to be seen, as not a coercive or even punitive thing, but we want to do this with you because we feel like you're worth it. And the other one I want to quote is Dr. Amador, who I think most of us know who he is. And he said that we succeed not on the strength of our arguments, but on the strength of our relationships. And I think it's easy to fall into a trap of, well, if it's a law, it's an order, then you got to do it. I don't know about you. I think most people don't like being told that they have to do something. That almost immediately makes them not want to do it. And so that's how I would like AOT to be seen. I also hope that they follow up on their pledge to put second orders back the way they used to be. And I hear also that they are looking at making it possible for like a psychologist or a nurse practitioner to testify in court for AOT. I don't know that it needs to be a psychiatrist, so I hope they do that.
Wonderful.
I'll go next. I think one of the things for me is it would be great if they could understand that it's great if you put policies into place, but also where's the money? Where's the funding? So like that really limits what success and the wins that we can do. So I think recognizing that, you know, it's great, you know, to try to put things in place but you have to think big picture. And especially I think of like some of these rural counties, you know, what they're very limited in what they can do. So I think that's one thing that's really important to take into consideration is it's looking at what your county can do, what they can accomplish. You know, if they don't have staff, you know, your wins are going to look significantly different. And it doesn't mean it's not a successful program. It's just really it's utilizing what resources you have, and that's sometimes all you can do. So I think, you know, that is one thing that I would really hope that they take that into consideration. And I'm always one that, you know, sometimes I wish they could come and just shadow people what they do for the day. That's just watch what we do, and you might, you know, you might change your tune. So I always say that. I'm like, you know, I love when I see people who start from the bottom and work their way all the way up who have that experience, you know, but that's I think the only thing I would say is maybe come spend the day with us.
Yeah. It looks like Julian said in the chat that us here at the CBHJ, we are telling everybody who will listen that this does need funding, because what we've seen, you know, up until this point is when CMHs have have the resources and the structure to be able to break down these silos and communicate with other systems and be able to really um, you know put power behind AOT, it really does make the world a difference. So yeah, we are definitely floating that message out there with everything we got. So lastly, we've only got a couple minutes left, but I did just want to share, or I wanted to put it out there if anybody had any wins, any successes that they wanted to share. Again, doesn't matter, you know, if it looks incremental or small or however. Is there anything that came up for anybody today that they'd like to share?
One thing I did want to note is that, you know, in the past couple of years that I've been doing this, I've been seeing the amount of CMH and outpatient engagement in the AOT process has increased, you know, exponentially. Just the amount of people that I have engaging, you know, with us, but also at saying, you know, CMH is being able to identify on their own people who might benefit from AOT, asking how can we, you know, how can we facilitate this? CMHs appearing in the court hearings, I think, has helped a lot of judges just kind of start to get the understanding that there are these different, you know, aspects to the system. You know, it's every little kind of increase in engagement like that, it makes a big difference across the board. You know, at StoneCrest, we take individuals from all over the state. At this point, I think I've done hearings in maybe 60 something different counties, and going from counties who probably haven't done a mental health hearing ever, seeing them, you know, just even those smaller counties kind of increasing their own engagement with the CMHs. There's definitely a lot of the education and the movement and the, you know, increased communication. There is definitely some changes happening out there, and it's encouraging.
Yeah, that's wonderful. Thank you so much for sharing that. Oops, sorry. Get out of here. Yeah, so with just the final 2 minutes left, I wanted to address, you know, that the bills, the AOT bills, have been passed in the health committee this week, and there should be a decision about whether they get signed into law soon here. We just want to let you know that we at the CBHJ, the AOT team, is monitoring that closely, and we will be disseminating, you know, as it, you know, turns into law, we will be disseminating what you need to know and how that affects you all in your positions, and we'll hold resources for that to talk about that and to see how that will play out. So it looks like Sophie put in the chat a summary of the bills and a link to that. So if you're interested, go ahead and check that out. But yeah, are there any final thoughts or questions before I close this out? No? Okay, wonderful. Well, thank you all so much for coming. Again, thank you panelists for coming and letting us elevate your amazing work. And I'm glad that we got this space today to elevate ourselves and to really define what success looks like in this work. So thank you so much. And I hope you all have a great rest of your weekend and stay warm.